I'm delighted to welcome everybody to the Department of Medicine Grand Rounds on March the 21st. We have, I think, a really fantastic talk for you guys today. Let me introduce our speaker first, and then I'll sort of say how this, how we happened to corral him to do this talk. Dr. James Law, Jim Law, graduated with honors from Duke and subsequently enrolled in the medical sciences training program at Ohio State University, where he earned his MD PhD with a focus on neurobiology and cell biology. After completing an internship in medicine, he completed his neurology residency at Emory before joining Emory as neurology faculty, where he is now an associate professor. Dr. Law is engaged in both clinical and basic science research, as well as clinical work. In his clinical work, he's developed a multidisciplinary team devoted to improving the care of patients with Alzheimer's and other brain diseases. He serves as clinical core leader and associate director of the Alzheimer's Disease Research Center, the director of the Cognitive Neurology Program, principal investigator of the Emory Healthy Brain Study, and director of the statewide Georgia Memory Net. Dr. Law has published over 180 peer-reviewed articles and has been awarded numerous research grants from the NIH and other agencies. In 2009, he was appointed the Alice and Roy Richards Endowed Chair for Alzheimer's Research here at Emory and was proclaimed an outstanding Georgia citizen in 2019 by the Secretary of State at the time, Robin Crittenden. I was originally really interested in all of the controversy surrounding aducanumab and the approval by the FDA for an expensive drug, and so had reached out to see if we could have a talk about that and Alzheimer's disease. I think that same week or so that I was reaching out, the new data came out about lecanemab. And it is clear that this is a time of real excitement and interest in, or real excitement and progress in sort of in Alzheimer's research. And so this is incredibly timely. And I'm so grateful to you, Dr. Law, for agreeing to give Medicine Grand Rounds today.
Thank you so much, Wendy. It's a real pleasure to be with you all. And I think it is a really exciting time right now, and it is a good time to get a bit of a refresher and an update on things. So I will go ahead and start my screen sharing, and hopefully this will continue to project well. Does that still look okay, Wendy?
It's perfect. It's absolutely perfect.
Right. So I'm going to spend first my disclosures. I do serve as a consultant for Roche Diagnostics. I'm in the midst of helping them develop their planning for FDA registration of their blood-based biomarker platform. But that's not going to be terribly relevant for my talk today. Learning objectives for today is really to understand the current state of Alzheimer's biomarkers, and then the important implications of emerging disease-modifying therapies. This is really a first step in a long process, but a very important first step. And then some unpublished, hopefully soon to be published work that we've been doing, trying to understand our limitations in understanding Alzheimer's disease in diverse populations. So the new therapies for Alzheimer's disease we'll talk about, but I want to go back to a happier time back in 2011 when President Obama signed the National Alzheimer's Plan Act, which had several goals. And the one that has always gotten the most play is the goal to prevent and effectively treat Alzheimer's disease and related dementias by 2025. And our own Alan Levy, during his stint as chair of the NAPA committee, also got added a fifth or sixth component, which is to accelerate action to promote healthy aging and reduce the risk of ADRD. And so I want to just spend a second or two talking about that, because I think no matter what we do in terms of medical interventions, the more we can do in terms of prevention, the better off we're going to be. And this is a great paper that was published by the Lancet Commission reporting in 2020 about modifiable risk factors for Alzheimer's disease and related dementias. And early life, in this case, before age 45, the biggest modifiable risk factor is low educational attainment. And by eliminating that, up to 7% of dementias in late life can be eliminated, estimated. And then in midlife, between 45 and 65, you see the ones listed here: hypertension, excessive alcohol, obesity. A big surprise to me was the impact of hearing loss in midlife, being a major contributor to reversible causes or modifiable causes of late life dementia. And then after age 65, two that really jump out: depression and social isolation, along with these others that you see, can all contribute to preventable dementia. And when you add all of that up, the currently sort of recognized modifiable risk factors account for about 40% of dementia that can be prevented altogether, and then 60% listed as risk unknown. And I think that many of these things we're going to learn more about. A lot of people focus on genetic risks, but I think that we're increasingly becoming aware of social determinants of health, which may be contributing a huge amount of risk. So one of the big changes in our common understanding of Alzheimer's, we've always kind of known this, but this has really crystallized in the last decade or so. And that is that Alzheimer's disease is a chronic condition, no different from heart disease or cancer. And just like heart disease or other chronic conditions, you don't all of a sudden wake up with severe dementia. This happens gradually over a period of many years. And during the course of 15 to 20 years, what you're seeing here in the green line is the increasing clinical symptomatology when memory loss and cognitive and functional decline set in. But during a 15 to 20 year estimated time period, there is evolution of silent pathology, the typical hallmarks of amyloid plaques and neurofibrillary tangles, development of hypometabolism and even volume loss before symptoms really set in. And so this is a really important concept, and I'm going to come back to that again. But this allows us to sort of set the stage for trying to understand this disease as a chronic condition. And so how we do that currently, I showed you that the pathologies are evolving for many years, and we can detect the proteins, the key proteins associated with the hallmark pathologies, these amyloid plaques and neurofibrillary tangles, by measuring the component proteins in the cerebrospinal fluid. So A-beta 42 is the primary peptide component that comprises these extracellular amyloid plaques, and then hyperphosphorylated form of the microtubule-associated protein tau, which you see in the pyramidal neurons here in the dark intracellular inclusions, is comprised of hyperphosphorylated forms of tau. And when those pathologies exist inside the brain, in the spinal fluid, the levels of the amyloid protein tends to be low, and forms of the tau protein tend to be elevated. So this is what we do when we're evaluating individuals. This is some old data. This was published over a decade ago now. Just showing that when you look at the spinal fluid from individuals who have Alzheimer's disease, the majority of them have this low A-beta on the x-axis and high levels of the tau protein on the y-axis, whereas cognitively normal individuals tend to have higher levels of A-beta and lower levels of tau. And where we use this the most often in clinical practice today is in evaluating people who have mild cognitive impairment. So these are people who are typically functioning very independently, but clearly have demonstrable impairments in cognitive function, most often in short-term memory. And in early stages, mild cognitive impairment is very difficult to discriminate from normal, healthy aging-related processes. And what we know is that in individuals who start off with mild cognitive impairment, so here we're looking at two groups of individuals with either a pathologic spinal fluid or a normal spinal fluid. They all have mild cognitive impairment at baseline. But if you have mild cognitive impairment and you have evidence of Alzheimer's pathology based on the spinal fluid profile, over the course of 5 to 6 years, virtually everybody in that initial MCI stage will progress to a stage of at least mild dementia. On the other hand, that's an individual who has mild cognitive impairment but has normal spinal fluid has less than a 10% chance of progressing in that same time frame. So this is, as a prognostic tool, this has been of great importance to us for many years, and we have been doing this routinely in clinical practice for quite some time. Another way to visualize the Alzheimer's pathology directly is using some PET tracers, including a number of PET tracers that will identify the presence of the amyloid pathology. A number of these are now FDA approved. We don't use this clinically because nobody's paying for the damn things yet, and it's extremely expensive. I had somebody get one recently, and I think they paid a little over $9,000 out of pocket to get it. But you can directly visualize with the PET tracers. This is somebody who basically has no amyloid pathology, so we're just looking at some mild background for the most part. But then in individuals, as they accumulate amyloid pathology, especially neocortical plaques, you see the PET tracer lighting up on the scans. And so you can visualize this both directly using PET tracers. There are also tau tracers now that can directly visualize pathology, and then indirectly by measuring proteins in the spinal fluid. So this takes us back some 30 years almost now to the amyloid cascade hypothesis of Alzheimer's disease. And I think I might have made this slide 30 years, well, not quite 30 years ago, but I made this slide quite a number of years ago, and I don't think I've really modified it since. And that hypothesis states that the accumulation of extracellular amyloid, these deposits, abnormal deposits in the brain, triggers a cascade of events that ultimately leads to neurodegeneration, synapse loss, and cognitive symptoms of Alzheimer's disease. And then a critical corollary that we recognized from the beginning is that if this is true, that doing something about the accumulation of amyloid should do something about the evolution and development of disease. And this can now be tested and is being tested directly. Not wanting to advance for me. What are you doing? There we go. And the way that this is being done, for the most part, there have been a number of things, number of studies looking at enzyme inhibitors, aggregation blockers, and the like. But really, for the most part, a lot of the strategy has been based on development of antibodies directed against the amyloid protein. And this can target the amyloid protein at different stages. So when the peptide is first released from the larger precursor protein, it exists as soluble monomers and then soluble oligomers and protofibrils that gradually aggregate into larger macromolecular structures. And so many antibodies have been developed, and most all of them failed to do anything, but they do have the ability to clear amyloid. Not all of them, but many of them do. And this is a series of images from 5 different patients. I forgot which antibody was being used in this study. It almost doesn't matter. But when you look at these individuals after 2 years of treatment with anti-amyloid antibodies, what you see is there is a significant clearance, and we'll just focus on this center panel. And what you see after 1 year and 2 years, the level of amyloid tracer signal in this scan is basically negative. This is what you would see in an individual that has no amyloid pathology. So this is something that we've known that we can do for a number of years. And Wendy mentioned aducanumab, and this was quite a controversial event, and I think it's very informative. And so I'm going to walk through the story of what happened with aducanumab and where it is now, and sort of I think what it hints at for where we're going later this year. So there were 2 large phase 3 trials of aducanumab, a study called Emerge and a study called Engage. And we actually participated here in the Emerge trial. And what we're looking at is a plot of amyloid PET signal in something called SUVR. And what you see in individuals who are treated with placebo in both of these studies, the levels of the amyloid pathology remain basically stable. But in individuals treated with aducanumab, over the course of 18 months of treatment, the amyloid was essentially eliminated in both of these studies. So there was a very significant reduction in the amyloid accumulation detectable by PET. And in the Emerge study, there was actually a statistically significant slowing. So here now we're looking at an upward trajectory indicating worsening cognitive and functional status. And in the placebo-treated groups, you see that steady increase. And in the Emerge trial, individuals who were treated with the highest dose of aducanumab actually started to show divergence and slowing of progression, so that by 18 months, there was a 22% overall slowing of progression. However, the ENGAGE study, which was designed almost identically, equally large size, had no significant difference in the clinical status of individuals who were treated with aducanumab. So this was the state of the science when FDA got hold of it. And what FDA did was they looked at aducanumab in a different way. So they used what is known as an accelerated drug approval pathway, in which a surrogate marker is used for clinical response. And some of you will remember that this protocol, this method for drug approval emerged in the 1990s in the height of the AIDS epidemic, when basically, being diagnosed with HIV infection was equivalent to AIDS and a sentence of death. And so at the time, there was promising work showing that there were drugs that could elevate CD4 count, reduce viral load, and those were felt to be very reasonable surrogate outcomes for clinical response. And so that's how this process came to be. And FDA decided, against the other recommendations of their advisory committee, that this should serve as a surrogate marker for clinical response to treatments. And so that was the process that led to approval of aducanumab by FDA. And then, of course, CMS did, I think, what was very reasonable given the evidence at the time. And they refused to pay for the drug, basically. They said that they would pay for the drug, but only in the context of a randomized clinical trial. So it basically threw aducanumab back into phase 3 or phase 4 trials. And it is, some people have received it, but it has by and large been unused because of the decision by CMS and insurers not to pay for the drug. But CMS did something interesting in their national coverage determination statement. And they extended their comment about amyloid-based therapies in general. And what they said in the coverage decision for aducanumab is that they would approve based on both the surrogate marker, removal of amyloid, and evidence of clinical efficacy. We don't know the strings that are going to be attached, because they did also indicate that they would be looking for additional data collection to better assess the clinical effectiveness of these medications. But the statement was that they would plan on approval based on standard evidence of clinical efficacy. So in December, the results of the lecanemab study, the ASI's Clarity AD study, was reported at a conference and simultaneously published in the New England Journal. And what the study with lecanemab showed was, as before, on PET scans, the amyloid burden. So on the top line, you're seeing the amyloid burden with placebo, and then after treatment with lecanemab. And basically after 12 to 18 months, it eliminated the amyloid, similar to what I showed you before. In their study, they also found a 27% decline or slowing of cognitive decline. So the placebo in the bottom here now, it's reversed. So they're getting worse as you go lower. And then the lecanemab treated individuals were declining slower. And this was on the heels of a phase 2b study that showed very, very similar results. And what was encouraging was that these results were pretty robust across all of the cognitive and functional measures that were incorporated as primary and secondary outcomes. And they also were consistent in their impact on Alzheimer's disease biomarkers. So remember, low spinal fluid A beta is bad. And in treated individuals with lecanemab, the levels of the A beta 42 protein went up. high tau and phospho-tau are bad, and treated individuals, those levels went down. So everything was extremely consistent. But before we get too excited, there are, in addition to efficacy concerns, there are also safety concerns. And so this shows, these are scans from the same individual. And this is showing something called ARIA, or amyloid-related imaging abnormalities. And this is maybe a little subtle, but what you see here in these black areas are areas of hemosiderin deposit, both a parenchymal and superficial siderosis deposits of hemosiderin related to microhemorrhages. And then down in the bottom, we're looking at flare sequences that are showing edema. So these whitish areas represent areas of edema in the brain that's associated with treatment with these anti-amyloid antibodies. Now, in most instances, these things are not symptomatic. In 80–85% of cases, they're simply imaging abnormalities. And after resolution, you see that the flare abnormalities are gone. Because this is iron deposition where there's been microbleeds, the hemosiderin deposits remain. In most cases, it's asymptomatic, but there have been some symptomatic cases. And there have been a couple of descriptions of pretty scary instances of death. And so, you know, this is not to be taken lightly. And I have a constant fear that people who've been using aducanumab and maybe getting lecanemab sort of willy-nilly without appropriate safety controls, that we're going to hear that shoe drop one of these days and hear about an avoidable complication or outcome. But for the most part, these risks can be managed. Oh, sorry, that was just a zoom in for those things. So now with lecanemab, we're at a different place. So they've already received accelerated approval based on the outcomes of their phase 2b trial. And in July, ASI is meeting with, they're scheduled to meet with FDA, and they're hoping to get full drug approval at that meeting from FDA in July. And then the question will be, what is CMS going to do? One of the things that is often debated when we talk about disease-modifying treatment like this is, what is the value of this treatment? What is the value of a 22% or 27% or 30% slowing of cognitive decline? These are very expensive drugs. The company has initially tagged this drug at about $26,500 a year, but there are also ancillary costs. If CMS is going to pay for amyloid PET scans, as well as a number of safety MRIs, these are biweekly infusions, so there are questions about infusion capacity. And then these risks of ARIA, which are substantial, upwards of 20% or nearing 20%, less than what was seen with aducanumab. And like I said, the majority of these, most of these are not symptomatic. These are the symptomatic ones. But in terms of clinical benefit, one way to look at this, and I think a reasonable way to look at this, is tracking the progression of patients from one stage of disease to a later stage of disease. So individuals who are treated in these phase 3 trials, phase 2 and phase 3 trials, were individuals with either mild cognitive impairment or very mild dementia due to Alzheimer's disease. And so you can track the stage of progression from mild cognitive impairment to mild dementia. And these are shown as steps because the measures that were being used were collected every 3 months. But if you sort of straighten that out and estimate what the impact is in terms of delaying the move from an earlier stage to a later stage of clinical disease, by 18 months, the estimated delay of progression is about 6 months. So going from mild cognitive impairment, where people are often still working in high level positions, to a stage of mild dementia where there's more functional limitation, I think most people would, most patients certainly and families would argue that that is a meaningful change. And then something that we don't know yet, consistently in these studies, we've seen a divergence of these curves when we see a positive effect. So there's even the potential prospect that this delay of progression may extend out even further. So this is really where the argument is coming now, because of the number of individuals who may be eligible for lecanemab, the enormous cost, what that's going to do to Medicare and other Medicare priorities, what that will do for its solvency over a long period of time are major concerns. And so we are all kind of waiting to see. You may have heard that the VA recently, last week, decided that they were going to approve lecanemab for use in veterans who are eligible for the drug. So this is, like I said, a first step, but a very important one. And the reason I say that is, I used to make this joke regularly. That, the problem with dementia is that the dementing illnesses is that you go from these very early stages where quality of life may be excellent, but as symptoms progress, and you reach later stage of disease, the impairments become much more profound, and the degradation of quality of life can be severe. And so the benefit of disease-modifying therapies is that if you can slow that down, even if we're not stopping anything, we're not reversing anything, but if we can slow it down sufficiently that people die of a heart attack, then the cardiologist loses, the neurologist wins, and everybody's happy. And this is a really important first step, because it's really these late stages of disease that are so dreaded by our patients. But it's a first step, because if we can impose these disease-modifying therapies earlier, we should be able to delay the development of disease and ultimately prevent disease altogether. And so I'm going to go back to this slide that I showed you before. And what we've been doing now, we've been talking about treating patients with these disease-modifying therapies at this MCI and mild dementia stage. Well, if that works, why the hell wouldn't we back it up to a point where we know this amyloid is accumulating, but we're much farther away from symptomatic disease? Logic would dictate that if this works in the MCI stage, it should work in the preclinical or asymptomatic stage. And in fact, that's been tested. The A4 study, which is the anti-amyloid and asymptomatic Alzheimer's study, started way back in 2013 or 2014. It got delayed because of the pandemic. But what was done in that study, in that trial, was that cognitively normal individuals over age 65 who had evidence of positive amyloid PET scans were treated with a different monoclonal antibody, solanezumab. This was a Lilly study. And treated, for 4.5 years. The data lock occurred in February. We knew the top-line results were going to be released this month. And I think many of us were already sort of pessimistic about what would happen with this drug. And the reason for that is we know from other studies, including something done by the Dominantly Inherited Alzheimer's Network, that the treatment with these drugs, solanezumab and gantenerumab, did not slow the progression of disease in that group. But more importantly, we knew from that study, while gantenerumab effectively eliminated the amyloid accumulation, solanezumab did not. And that's because of the target of solanezumab is those monomeric A beta peptides rather than the protofibrils or partially aggregated A beta forms. And so it does not remove amyloid from the brain. And in fact, a couple of weeks ago, Lilly released the top line results. The A4 study released the top line results. Solanezumab did not slow cognitive decline in these asymptomatic individuals, and treatment did not result in clearance of brain amyloid. I've got a meeting with our A4 participants this afternoon to talk to them about what options they have now that this study has proven to be another failure. And one of the options is this. This is something called the AHEAD study. It has two components, an AHEAD 3 and AHEAD 4/5. And these are, again, secondary prevention trials for cognitively normal individuals over the age of 65. They have to have a positive amyloid PET scan, and depending on the amyloid burden, you go into one of two randomization arms with either lower dose or higher dose of lecanemab. And so this is the same drug that we've been talking about that we anticipate getting standard FDA approval. And this study is currently enrolling. I'm actually, unlike the A4 study, because of what we've learned over the last 10 years, I'm actually quite optimistic about the prospect for this study showing a positive signal. So I'm going to switch gears now and talk about some things that we've been doing, which I think meshes well with where the field is in terms of evolution of treatment. And there are some challenges. So we know that we can detect silent Alzheimer's disease, asymptomatic pathology. What we can't do is we cannot yet say if you have positive PET scan or you have a positive spinal fluid profile for Alzheimer's disease, I cannot tell you whether you're going to get Alzheimer's disease ultimately. Lots of people die with a brain full of plaques and tangles that never get any symptoms of Alzheimer's disease. So if you're not going to get any symptoms, I should just leave you alone. And so that's an important unanswered question. And then something really important that we've been focused on for the last 15 years here at Emory in our Alzheimer's Center is understanding Alzheimer's disease in minority groups, especially in African Americans. And so I'm going to spend some time talking about some work that we've been doing in that space. So much of this is done under the auspices of the Emory Healthy Brain Study. This is a project that was launched back in 2016, was recently funded by NIA in 2021. And the goal of this project is to identify predictive AD biomarkers. And since we know that Alzheimer's disease is believed to be evolving for 2 decades, we said, well, most people get Alzheimer's in their 70s and 80s. So what we're going to do is we're going to study people mainly in their 50s and 60s. So that's who we're enrolling. We're currently at about 1,850 volunteers. We're aiming for 3,000, including 1,000 African Americans. These are all cognitively normal volunteers. They come for biennial visits. They have detailed cognitive testing. We do cardiovascular physiology measures. We do brain MRI and functional MRI. We collect both blood and spinal fluid. So all of these people volunteer to have lumbar punctures every couple of years, and it's wonderful. It's amazing, this group of folks. And then we apply a number of different analytic approaches with a large group of collaborators working on this project. So this is how we've been doing so far. So by the end of 2022, we had 1,805 total participants with 3,100 total visits. We've got people coming up on their 4th visit now. So this is now, what is that? So 6 years after their baseline visit. So we're starting to get a significant amount of longitudinal data with 1,800 people having completed 2 visits, over 800 having completed, 1,800 baseline visits and 800 having completed 2 visits and almost 500 having completed 3 visits. At the start of this project, we didn't do a great job of having a diverse participant group, but we've done much better. Since 2021, we've had 68% white participants, 27% African American, and 5% other minorities. So we're aiming to get this number up to 33%, and we'll get there. And why are we focusing on African American participation in this and other studies that we did here? Well, we know that CDC estimates that Alzheimer's disease is projected to triple by 2060 in the US. But among individuals over age 65, and this is relatively conservative compared to some other estimates, but among individuals over age 65, CDC estimates about 10% prevalence of Alzheimer's disease in non-Hispanic whites, and 14% in African Americans, 12% in Hispanics. So significantly higher burden of disease in minority populations. And this is some older data, but this is a really good study that was done, published back in 2016, and this was done in Kaiser of Northern California, who followed a cohort of individuals over age 60, and then tracked incident dementia from 96 to 2013. And the reference group in this case is Asian Americans, who had the lowest rate of of dementia. Non-Hispanic white individuals were about 25% higher, and African Americans were over 70% higher. So a substantially higher incidence rate of dementia in that population. There's another very well-known study called the Washington Heights Inwood Columbia Aging Project, where investigators go into the community to evaluate individuals on a population-based cohort. And so they started with a dementia-free cohort over age 65 and looked at incident dementia that was then characterized as AD based on the then current diagnostic criteria. And I'll come back to this. But again, you see that relative to non-Hispanic whites, across different age brackets, the rate of Alzheimer's disease was estimated to be more than twofold higher in African Americans than in non-Hispanic whites. So this is a big difference in burden of disease. And so I want to go back to the biomarkers for Alzheimer's disease. Now, how do we know what's Alzheimer's disease in these biomarkers? Well, there's a landmark study called the Alzheimer's Disease Neuroimaging Initiative, the ADNI study. It is now entering ADNI 4 with a very large NIH grant. But to this point, ADNI has been 92% white, 4% African American, and this is actually an improvement from what it was in ADNI 1 and ADNI 2. But this has been a pivotal study in helping us to understand Alzheimer's fluid biomarkers as well as imaging biomarkers. And then for the fluid biomarkers, there's something called the Swedish Biofinder study, which has also contributed a great deal of information about our understanding of spinal fluid biomarkers in Alzheimer's disease. And I don't know this for a fact, but I'm guessing SCAN, or however you pronounce that, and Angelholms hospitals are going to be overwhelmingly individuals of Northern European descent. And so this classification of AD versus normal spinal fluid profile, that comes from these populations. Most of these studies come either from ADNI or Biofinder. And they have very poor representation of non-white populations. In our efforts here, we have collected spinal fluid protein samples from a lot of people. So this was an analysis that I've done recently on over 3,000 spinal fluid samples from roughly half cognitively normal volunteers, almost 900 with Alzheimer's, and 660 from our clinics with non-Alzheimer's diagnosis, and almost 500 samples from African Americans. So now we had the power to examine racial differences in what we think is a conclusive way. And this is a pretty busy slide, but let me walk you through this because I want you to understand some of the complexities of this. The easy part of this is the tau proteins. This is total levels of the tau and the phosphorylated form of the tau. And this is in cognitively normal versus Alzheimer's patients, Caucasian and African American. And consistently in all of these groups, cognitively normal, Alzheimer's disease, Caucasian individuals versus African American individuals, the levels of the total tau protein and the phosphorylated tau protein are consistently 20 to 25% lower, whether you're cognitively normal or you have Alzheimer's disease. And this is very consistent. There have been 3 smaller studies that have reported some very similar findings in Alzheimer's patients. What's completely new here, though, is this. And previously, among patients with Alzheimer's disease, the levels of the A-beta 42 protein were reported to be basically no different between Caucasians and African Americans. And we find a small difference, but a modest difference, 9% lower level of A-beta among Alzheimer's patients who are African American versus Caucasian. But when we look at cognitively normal individuals, there's a profound difference between the levels of the A-beta protein among African Americans and among Caucasians. And this is something that has not really been reported before and has a big impact on how we deal with this, because having recognized that tau proteins tend to be lower among African Americans, there's been discussion about, well, maybe we need to set different diagnostic thresholds. That's hard to do because these changes are very complex and differ among the two major analytes that we're analyzing in the spinal fluid to make a determination of Alzheimer's disease. So, but that's where we are. And so what happens? So let's go back and look. So we have these cutoffs from ADNI and from BioFinder and other predominantly from individuals of European ancestry. What's the impact of applying those cutoffs on African Americans? This is too busy of a slide, but it's just looking at sensitivity, specificity, positive, negative predictive values at different cutoffs from ADNI. And so I'm just going to focus on this one because that's the biggest difference that we see. But for phospho-tau in ADNI, the cutoff was if you were greater than 27 picograms per mil, that was the cutoff for the best discrimination between controls and Alzheimer's disease. The sensitivity in Caucasians isn't great, 63% at that cutoff value. The sensitivity among African Americans is 47%. And you see this consistently across all of these cutoff values where there are distinct lower sensitivity and also lower positive predictive value in most cases lower negative predictive value among African Americans when you use these ADNI cutoff values in African American populations. Now, this is from the research samples and the research assays, but we do this in our clinic. I told you we use these spinal fluid markers and we send them to the lab for testing. And the lab that does this is Athena. And so I had about 1,000 results from our clinical experience. And Athena uses an algorithmic interpretation to call the spinal fluid Alzheimer's disease, not Alzheimer's disease, or equivocal. And so when you look at the rates at which individuals are deemed to have equivocal results, it's about 27% in Caucasians, but it's 39%. The odds ratio of getting an equivocal result based on the clinical spinal fluid test that we use is 1.75. And so this has real impact, the fact that we have results that we're applying from populations that may not be applicable. Now, we were talking about asymptomatic Alzheimer's disease. And so with our large number of cognitively normal individuals, we can now estimate the prevalence of asymptomatic pathology in cognitively normal individuals. And so this is broken up in 5-year increments. And between ages of 50 and 55, we find about 4.7% evidence of asymptomatic pathology, but by the time you get into the age group of over 75, it's nearly a third. So this is exactly as expected and has been reported in a couple of different meta-analyses. But what we found that was really disturbing is that when you look by race, among Caucasians, the estimate for asymptomatic pathology is 13.4%. The estimate for asymptomatic pathology in African American controls is only 8%. And so, the presumption was, well, we're using a flawed cutoff, and that's giving us these terrible values that just are not accurate. And so what we did, my biostatistics collaborators did, was to develop a data-driven model for examining the spinal fluid. So I don't know if some of you may be very familiar with Gaussian mixture models and even Gaussian mixture of regressions. It was all Greek to me. But this is how I understand this. So in the spinal fluid, you can look at the distribution of A beta or tau or phospho-tau, and there is an underlying distribution in the group that you're looking at. So if this is A beta, we may be looking at lower A beta levels associated with the Alzheimer's component of the population and higher levels in the control. And what you see is this overall distribution, and you ferret out the underlying distribution. And by identifying the intersection point, you can identify the point at which you are of equal probability of being in group 1 or group 2. And so this is how people often set thresholds and cutoff values. And the cutoff values are often based on a ratio of tau to A beta so that you get information about both tau and A beta, but you get a single value. That doesn't work for us here because we know that there are independent effects of race on A beta and tau. So the model that we created was a Gaussian mixture of regressions that looked at each of those individual distributions, combined them in a single model, and then adjusted for covariates, including race. And this is what this looks like. So this is just a scatter plot. And what you're seeing here are individuals who were diagnosed with Alzheimer's disease in the red or pink, and then individuals who are cognitively normal in the green. And then these dots in blue are those 600 some odd individuals who had non-Alzheimer's diagnoses. And so because they have non-Alzheimer's diagnosis, they have something else. But from the standpoint of Alzheimer's disease, they don't have Alzheimer's disease. So when we model this using the Gaussian mixture of regressions, most of those other diagnoses fall into the control like group, these ones in green. Some of them fall into the AD-like group in red, and then there's a group of about 5% outliers that don't fall into either one of those categories. So the model actually allowed us because we couldn't set a single cut point, we created an app in R Shiny, posterior probability calculator. And what this allowed us to do was to input any number, any value for A beta, total tau, phospho-tau, and then adjust for race, sex, APOE status. And then it will give you a posterior probability of what that individual likely has. So an AD-like probability, control-like probability, or other probability. So what we did was, remember, this was, we thought that this was due to using the ADNI cutoff, falsely classifying African-American controls. So we did this using our GMR model, and guess what? The estimate for asymptomatic Alzheimer's disease among cognitively normal Caucasian controls was almost exactly the same as what was found with the ADNI cutoffs. But look what happens with the African American controls. It's slightly higher. It went from 8% to 9.3%, but it remains significantly lower than what you see among cognitively normal Caucasians. So what the hell is going on here? So we think we know that Alzheimer's disease is almost twice as common in African Americans as it is in Caucasians. But remember, I said this was based on the 1984 diagnostic criteria, which is purely clinical criteria. You had to be impaired in memory in another cognitive domain. There had to be progressive memory loss, and then no alternative explanation. So we treated Alzheimer's diagnosis as a diagnosis of exclusion. None of these studies incorporated biomarkers in determining Alzheimer's disease as the underlying etiology for these changes. And so there are a number of really important conclusions. One is that, as expected, the accuracy of spinal fluid diagnostic tests, as they're currently applied, is less accurate in African-American patients than in Caucasian patients. And so that may well lead to greater misdiagnosis. Lecanemab and other emerging disease-modifying therapies should only be offered to individuals who have confirmed Alzheimer's pathology. So if we have greater uncertainty or are less sensitive at detecting AD pathology in African-American individuals, are we going to be denying individuals who might benefit from these disease-modifying therapies because of how we approach that diagnosis? And then what does it mean? So if Alzheimer's disease is supposed to be almost twice as common in African-Americans than in Caucasians, well, if that's true, I should see an equally elevated rate of asymptomatic pathology. I didn't go through this in detail, but those cognitively normal controls were extremely well matched between African-American and Caucasian populations in terms of age, gender distribution, APOE status, even education, because we have, in our research cohorts, they are, it's just like other research cohorts, they tend to be overeducated and too affluent. We don't do a very good job of getting diverse SCS. So if that's not the case, then what's causing the higher rates of dementia? Because there is no question that dementia is a higher burden in minority populations, but what's causing that? And then another alternative explanation that I'm not really going to get into, it gets a little speculative, but the possibility that Alzheimer's disease follows a very different clinical course in African Americans compared to non-Hispanic white individuals. So with that, I'm going to stop and acknowledge some of my incredible colleagues and collaborators. I want to particularly highlight Monica Parker, who has been my key partner since 2008 in engaging African-American groups, churches, social organizations, and the community at large to get this incredible participation in our studies here, along with many other collaborators here. The folks in biostats, including a very talented graduate student who did the Gaussian mixture modeling as a part of his dissertation work. He's now, of course, working at Amazon, and other colleagues in biostats. I didn't get a chance to tell you about some of the proteomics work that we've been doing, or some of the machine learning modeling, but some really interesting work coming out of there. And our funding sources, the participants and staff who make all of this possible. So thank you very much. And I think we have a few minutes for some questions if there are any. And if not, I have a couple other things I can share with you.
I think you're going to have some questions. And first off, I see our chair, David Stevens, raising his hand. So Dr. Stevens, feel free to unmute.
Hi, Jim. Thank you very much. Great talk, great overview, and congratulations to the field on lecanemab. Looks like a first step in the right direction, if you will. My question really has to do with tau-mediated injury, and we're obviously not fully reversing decline with lecanemab. What about tau-mediated approaches, and where does that stand, and is a combination in our future for this disease?
Yeah, great question, and the answer is absolutely yes. So because we think that the evolution of tau is a little bit later on in the course of disease, and the burden of tau on tau PET scans, the anatomic distribution and burden of tau appears to correlate better with cognitive decline than amyloid burden does. Amyloid burden, by the time people are symptomatic, is largely plateaued. You can eliminate it, but if you just watch people over time, it doesn't tend to accumulate a great deal during symptomatic disease, whereas tau does. And so one of the strategies that's being implemented now, I mentioned the DIAN study, the dominantly inherited Alzheimer's network. It's a very small cohort, but it's a very powerful cohort because these are people carry genetic mutations with predictable age at onset of disease. And so what's happening now in the clinical trials that we're doing as part of DIAN is we're bringing people in and they're initially getting lecanemab, and then we're testing an anti-tau monoclonal antibody in a randomized fashion. And so the hope is that if lecanemab and other anti-amyloid treatments are effective, partially effective, that we can get an additive or synergistic effect by applying that to tau. And so those are really encouraging developments, but I think that there are going to be other targets. Some of us are sick and tired of hearing about amyloid and tau at this point, and there's a lot of work and interest in inflammation and modifying microglial function, looking at metabolic perturbations. So different targets and different strategies, and ultimately I think we're going to wind up with a cocktail that may be stage specific and hopefully at preclinical stage of disease, and we're working on biomarkers that appear to track with different preclinical stages of disease as well.
Great, thank you. Great talk.
Thank you.
That's super interesting. There are several questions in the chat that sort of revolve around a similar question, which is the role of APOE sort of markers and genetic testing, the amyloid plasma panel that Roche has rolled out. What do you feel that the role of this kind of testing is?
So a couple of things. So APOE genotyping is not, it's been available forever, and we typically haven't done it because I found it to be of limited clinical utility. And plus, nobody will ever tell me if the damn companies, the insurance company is going to pay for the damn thing. But I haven't found it to be terribly useful. But with lecanemab and anti-amyloid antibodies, there is an increased risk of ARIA in individuals who are E4 carriers, and particularly in E4 homozygotes. And so we're debating whether or not we should include that as part of our risk stratification as we consider prescribing lecanemab to our patients. In terms of the diagnostic testing, the Roche panel, which is, it's still getting tested. It's just being tested now. And there are other plasma measurements, mostly focused on measurements of individual phosphorylated tau moieties that can be detected in the plasma. But the Roche panel actually includes proteotyping for APOE. So they do a combination of a phosphorylated tau marker and looking for APOE4 specific peptides as part of their plasma panel. And I think we've started using some of these plasma biomarkers prematurely in some of our clinical trials because they're just not quite accurate enough yet. And again, I do advise Roche on this, so in the interest of disclosure. But I think they're taking a good strategy here because they're developing their blood-based biomarker panel to serve as a very good rule-out test, a very high negative predictive value test, so that if you get a negative result on their panel, you can feel fairly comfortable that your patient does not have underlying Alzheimer's disease. And if you can't rule it out, then you may need to send that person for further, more detailed, specific evaluation. But the plasma biomarkers are going to become critically important, and we're also going to have to figure out how to use that in the clinical setting in primary care and other venues.
I always like to spotlight the resident questions, and so we have one from the Grady resident room. Do you have comments on whether the difference in biomarkers between or incidence between African American and Caucasian populations are due to genetics or underlying social determinants of health like racism, poverty, pollution, access to nutrition, et cetera?
Yeah, wonderful question, and something that as I mentioned, I think I don't know, you geneticists out there may disagree with me, but I think ultimately social determinants and lifetime exposures and experience are going to wind up having a bigger say on our health and disease than our genetic makeup. And
here's the geneticist. Just want to interject, Dr. Law. It's good to meet you finally. No, I don't disagree with you at all, believe it or not. Genetic determinism has done a lot of harm to our specialty. And I think environmental factors weigh very, very heavily in Alzheimer's and in a lot of these late onset neurocognitive phenotypes. So I agree with you on that.
It's a very hard thing to quantify. We're working on ways to try and calculate a lifetime exposure metric. But what I will say about these, this is sort of a paradoxical result. If you come from the standpoint of Alzheimer's disease is more common in African Americans, finding a lower rate of asymptomatic disease in African Americans is paradoxical. However, I've been staring at an estimated coefficient matrices for months. I think that thing is spinning in my brain constantly while I'm sleeping, and I woke up with another alternative explanation, and I don't like it. But it fits with the question and possibility of impact of social determinants of lifelong exposures. And that is that if groups have lower resiliency, so we know that access to higher education, better healthcare, better nutrition, wealth, safety, transportation, we know that all of those things can actually contribute to greater resiliency against age and disease-associated changes. So the coefficient for African American race on amyloid beta is huge so in cognitively normal individuals. In fact, it's the equivalent of 3 decades of greater age. And so the alternative explanation for the paradoxical result is that Alzheimer's disease may have a shorter prodrome, a shorter asymptomatic period in individuals who may have less cognitive resiliency. I'm not putting that in the paper because it's too speculative, But I think that is a potential alternative explanation for higher rates of Alzheimer's and dementia and lower rates of asymptomatic pathology. It's a very disturbing possibility. But again, if our work does anything, I think it's going to highlight the fact that the risk of not having this diversity in our research enterprise is going to continue to contribute to disparities in our healthcare.
And on that note, we are actually beyond the top of the hour. So I want to thank you so much. This was a fascinating talk and beautifully presented, and really I learned a ton. So thanks so much.
Thank you so much. Good to see you all.